Does an abnormal heart valve need a surgical intervention or not? How do you go about evaluating this clinical dilemma? Well, I have just the tools to share with you in this episode of Tea Time. Welcome to Tea Time. I'm Dr. Andreas Plackis, and this is Episode 9, Native Valve Evaluation. The clinical question that we're going to address is, what factors must a clinician consider when thoroughly evaluating a native heart valve for possible intervention? If there is one thing I want to hammer home from this podcast episode, it's the material in this quote. Every heart tells a story, and each picture is worth 1,000 words. Every heart tells a story, and each picture is worth 1,000 words. This essentially explains to us that when there's heart pathology, one thing leads to another. You can see your evaluation as a story that's unfolding before you. There's far more that goes into decision-making for valvular intervention than simply echocardiographic severity alone. We need to look at the whole patient. So some of the indications for possible intervention are the presence or absence of symptoms, the severity of the valvular heart disease, the response of the LV or the RV to either volume or pressure overload that's caused by valvular heart disease, and also the effects on pulmonary or systemic circulations. And when we look at our overall goal for why we would even consider intervening on the valve, we need to make sure that it would benefit the patient in one of the following ways, whether it improves their symptoms, prolongs survival, or minimizes valvular heart disease-related complications such as ventricular dysfunction, pulmonary hypertension, stroke, or atrial fibrillation. If you're not going to accomplish one of these goals, it's far less likely that you're going to want to intervene on the valve. So let's get into the actual assessment now. There's 6 different criteria that I use, and these include the clinical information, 2D echo, Doppler echo, quantitative measurements, 3D echo, and then other echocardiographic data or non-echocardiographic data that you may find as well. So let's start with number 1. When it comes to the clinical assessment of the patients, things we want to consider are the history and symptoms of the patient, certain physical exam findings, laboratory values, and also vital signs, as these can come into play, especially during echocardiographic assessment of the patient. As far as the clinical assessment of the patients, we'll start by looking at their symptoms. Are they symptomatic or are they asymptomatic? That is a major differentiator in whether you would intervene on a valve or not. If the valve is severe enough that it's affecting the patient negatively in their quality of life versus if it's not even interfering with their quality of life or causing them symptoms, this is a major differentiator. So I would ask myself, are they having dyspnea on exertion, fatigue, or anginal symptoms that may be caused by other things such as coronary disease? I try to discern if there are symptoms caused by the valvular disease itself. This is less of a perioperative question and more a question cardiologists may ask, but if symptoms are equivocal or the patient lives a very sedentary lifestyle, there's an opportunity to perform exercise testing to help unmask the presence of symptoms to see if they do have a valvular disorder that could be causing symptoms. Next, we consider physical exam findings. Is the patient having signs or symptoms of volume overload? These would include inspiratory crackles, pitting edema, jugular venous distension, or even weight changes and weight gain. Lastly, we'll look at laboratory findings. Is the BNP significantly elevated? Are there any signs of kidney or liver dysfunction with elevated creatinine or elevated liver function tests? Are there new oxygen requirements? In very severe cases and cases of cardiogenic shock, is the lactate elevated? These are all important non-echocardiographic factors that go into the clinical assessment of the patient. A couple other factors that are relevant here are looking at the blood pressure and the heart rate during your assessment. One thing to note is that an increased heart rate will cause an increased mitral valve gradient. You'll notice some of the recommendations for mitral stenosis all fall within a heart rate that is assumed to be between 60 and 80 beats per minute, because a moderately stenotic valve could potentially look severe at higher heart rates. So we need to note the heart rate at the time of the exam. Severe hypertension can also affect how the gradient looks through the aortic valve. Measurements of aortic stenosis severity when a patient is hypertensive can either underestimate or sometimes overestimate stenosis severity. And that's because systemic hypertension can impose a second pressure load on the LV, which can result in a lower forward stroke volume and therefore a lower pressure gradient than when a patient would be normotensive. Also, hypotension and hypertension can change the MR or AR severity, whereas hypotensive states may make a regurgitant lesion look less severe, and hypertensive states will increase that pressure gradient back through the valve and could make that valve look a lot worse and more regurgitant. So we need to keep in mind both the heart rate and blood pressure at the time of the assessment. In step 2, we begin our echocardiographic evaluation with the 2D assessment of the valve, focusing on both leaflet structure and function. We'll start with leaflet structure. Some of the things that we'll want to note are the presence of calcifications, thickening, or vegetations on the valve, as the way that the valve leaflets appear can actually influence surgical intervention. An example of this is in rheumatic mitral stenosis. One of the interventions might be a percutaneous mitral balloon commissurotomy, whereas we don't perform that intervention in calcific mitral stenosis and tend to prefer surgery in those patients. It also can influence the feasibility of repair, as oftentimes it's much more difficult to successfully repair a valve that has significant calcifications or thickened leaflets that don't function properly. In addition to looking at the valve leaflets, we're also going to look at the valve annulus and assess for dilation. This is important to delineate the mechanism of a regurgitant jet. It's also important if we're considering a valve replacement to consider, especially for an aortic valve, the sizing of the annulus, which may inform the surgeon. In addition to leaflet structure, we're also going to look at leaflet function. The way the leaflets move is very important, and these can be characterized as prolapse, flail, restriction, tenting. Some of the ways that we can organize these thoughts in our head are for the mitral valve looking at the Carpentier class, or for the aortic valve, the El-Khoury classes, which can actually help influence repair versus replacement decision making. It's helpful in your mind when you assess a valve to try and place the valve in one of these categories, even though sometimes there can be mixed etiologies. Trying to focus on what specifically is the cause of the valvular dysfunction can help you really narrow in on what the mechanism is and what to do about it. Understanding the valve anatomy and structure can be very important in this part of the assessment, as the mitral valve consists of the whole mitral valve apparatus with very complex interplay of the left atrium and the left ventricle, where there can be multiple factors that contribute to valvular dysfunction, and also understanding how the aortic root affects the aortic valve. One factor can influence the other. Every heart tells a story. For competent valves, some of the normal values we'll see are for the mitral valve, 8 to 10 millimeters of coaptation length. For the tricuspid valve, 4 to 9 millimeters of coaptation length. And for the aortic or pulmonic valve, we want to see at least a few millimeters of coaptation length to say that that is normal. Part 3 of our echocardiographic assessment will be looking at Doppler echocardiography, and this will include color Doppler and spectral Doppler, with spectral including continuous wave and pulse wave Doppler. Regarding the assessment tool of color Doppler, one thing that we'll note to start is both the jet site and direction into the receiving chamber. Is it a central jet or is it eccentric, as these could indicate very different types of valvular pathologies. Another important part of color Doppler assessment of the valve is looking at the jet components. And there's 3 pieces of information you can get here. 1, looking at the flow convergence. 2, the vena contracta, or the narrowest part of the jet. And 3, looking at the jet area. And it's often measured as a percent of the chamber, such as the right atrium or left atrium, or the LVOT or RVOT. And in this valvular assessment algorithm, in this picture, you can see for chronic aortic regurgitation, these 3 parts are all included in specific criteria for severe AR, such as a vena contracta width greater than 0.6 centimeters, a central jet with a width greater than 65% of the LVOT, or a large flow convergence. The next part of the Doppler assessment is using spectral Doppler to assess a valve when it's indicated, and this includes, as we mentioned, both continuous wave and pulse wave Doppler. One of the first things we'll look at with continuous wave Doppler is the density of the jet velocity signal. If there's a lot of regurgitant flow towards the jet, you'll see a greater density signal. Also, it's important to assess the contour of the jet. In both MR and TR, an early peaking or a cutoff sign can indicate a large regurgitant wave in the respective atrium and significant regurgitant jets. Also, for the aortic valve, slow onset in a parabolic shape with a longer acceleration time could indicate worse aortic stenosis, whereas this dagger-shaped waveform could indicate a dynamic LVOT obstruction. Another part of the spectral Doppler assessment includes using pulse wave Doppler to assess for flow reversal. When we're assessing both MR and TR, we're going to look for flow reversal in either the pulmonary or hepatic veins during systole. When looking for AR or pulmonic regurgitation, look in the aorta or PA branches in diastole. Other components of the assessment that we can look at are pressure halftime and also LV and RV filling dynamics for volume overload. The fourth part of our valvular assessment includes quantitative measurements. Even though continuous wave or pulse wave Doppler may be used for some of these were included differently as they may be more mathematical or quantitative calculations for valvular assessment. Some of these include the mean and peak gradient, velocities, or a dimensionless or Doppler velocity index. Also, the continuity equation is a pretty common math formula, especially for evaluating different parts of valvular stenosis. You can do 2D planimetry and also consider using PISA for EROA calculation. PISA formula can be very complicated and difficult to assess, so I opt to use what we'll see in certain ASE algorithmic guidelines where we simply look at the PISA in MR and change your Nyquist to 30 to 40 centimeters per second. And if that PISA radius is greater than 1 centimeter, that's one criteria for severe MR. And in TR, if that PISA radius is greater than 0.9 under the same conditions, then we'll consider that one criteria for severe TR. I find that to be a much quicker and simpler assessment in the perioperative setting. When it comes to some of these quantitative measurements, a piece of advice that I have is to memorize the moderate values. There's a lot of different values that you can have to learn, but if you memorize just the moderate ones, anything less than that will be considered mild, and anything more than that will be considered severe. So it gives you a third as much to remember, but it still informs you just as much. The fifth part of our valvular assessment is looking at 3D echocardiography. There's some important advantages to using 3D echocardiography when assessing a valve. It helps with localizing the valve pathology as you're looking at a three-dimensional valve and can use multiplanar reconstruction to help assess the exact location of where that pathology is. For regurgitant jets, using 3D vena contracta area can be an important and accurate way to assess EROA. I do a 4 to 6 beat acquisition when I acquire this to give me my best resolution image. For stenotic lesions, using 3D planimetry to assess valve area can be an important way to minimize the risk of either underestimating or overestimating the valve area seen with certain other methods. Our last step, step 6 in native valve evaluation, will be looking at other echocardiographic data and other parts of the heart. A key part of this will be looking at LV or RV size and function. For regurgitant jets, we may expect to see eccentric hypertrophy, which would be indicative of volume overload. And for stenotic lesions, we would expect to see concentric hypertrophy, which would indicate a pressure overload. This would occur in the LV for aortic stenosis or the RV for pulmonic stenosis. Remember, every heart tells a story, and the type of hypertrophy tells the story of what the heart has been experiencing. Looking at the LA or RA size can help us understand if there has been significant volume or pressure overload in the heart. A normal left atrium excludes severe chronic mitral regurgitation, where we would expect a very enlarged left atrium. Certain other key features include looking at the left atrial appendage and assessing for thrombus, other valve diseases that may present a mixed picture and complicate the valvular assessment. We also want an estimation of the PA pressure, as understanding how valves may affect the PA pressures and pulmonary circulation are important. And then at this time, we'd consider any other advanced or specific measurements that we may want to obtain. So this is a summary of the 6 steps of native valve evaluation. Feel free to screenshot this if you think it would be helpful to you of your intraoperative assessment of native valvular dysfunction and severity assessment. Key points that I want us to take away from this include point 1, look at the whole patient during your assessment. Using just echo, it's so easy to focus on specific echo criteria, but we need to think about patients as a whole picture and a whole patient and think about both the non-echocardiographic and echocardiographic findings. Remember, we presented 6 steps in this. So point 2 is know all your tools for valvular assessment. The more tools you have in your tool belt, the better you're going to be at assessing these valves. And point 3, I've said this a few times, is that every heart tells a story, and each picture is worth 1,000 words. We can understand heart pathology better when we understand how each abnormal or normal finding fits into that story. For the next episode, episode 10, we're going to start focusing on specific valvular surgeries. So it will be TEE for mitral valve surgery, and we're going to use this 6-step system to evaluate mitral regurgitation. All right. Thank you guys for watching. If you want more of this content, hit that subscribe button and leave us a review. Also, one thing that's important here is that we all continue to learn from each other. If you do something different at your own institution, drop something in the comments sharing your experience so we can all keep learning from each other. But thank you guys again for watching. We'll see y'all next time.